I'm going to present some of the work that we did during one of our medical missions to Uganda. So medical missions are a very important component of our School of Pharmacy. So what we aim is to provide healthcare to underprivileged people and populations around the world. And we do this as part of our program. So medical missions is not unique to PBA. Well, what is unique to PBA is that we have our Gregory Center for Medical Missions as one of our centers of excellence to really drive forward the medical missions, not just here on campus, but basically throughout the world. Medical missions are part of many educational programs, including, of course, medicine, nursing, but also pharmacy. A lot of people don't really think about pharmacy as a source for medical missions, but it is an important component. And it is not just that these schools organize medical mission trips, they are part of the educational program. So they are part of experiential programs. For example, with our pharmacy program, some of our rotation students, our fourth year pharmacy students, they can take an elective, and one of the electives they can take are medical missions. So they practice pharmacy while on the mission field. So Gregory School of Pharmacy has been very involved in medical missions, basically from the start of the program. And we've organized many trips to various parts of the world, Central and South America, Africa, Asia, but also domestically in our own county, Belgrade, and surrounding areas, but also in Alaska, Georgia, and other parts of the US. And what's done is healthcare is provided, health screenings are done, medications are dispensed, and health talks are organized. So what is the impact of medical missions? Well, there's basically a twofold impact. One impact is the people we serve. So there's the local communities where we go out and help them. So they receive free or free healthcare, at a very low cost, but typically it's free. And they will have access to doctors, nurses, diagnostic tests, and medications. We also want to empower them to improve their health, so they get tools to improve their health. We do talks about hygiene, for example, or malaria prophylaxis, and other things that they can do. And that's really important because it's one thing to provide healthcare. It's better to prevent the need for healthcare. And because PBA is a faith-based institution, we also bring the gospel. Students also benefit from these medical missions. So they gain awareness of completely new cultures, but also in a completely new setting. I always tell students the last time you'll see an AC is when you get off the plane. And for a lot of them, that's kind of a shock. You may or may not have hot water to shower, just so your personal experience is already different, but then also you interact with people, and people who are patiently waiting 8 to 10 hours to be seen by a doctor versus we get upset after we wait 20 minutes at a doctor's office. They also learn to serve these people. These are long days, like I said, they have to give up some of the luxury that they have here in the US. They pay money to go there and help and serve these people. And they also see the reward of service because these people are very, very glad that people are coming to help them. So why this is a part of the experiential program is because they apply the knowledge they've learned in the classroom regarding pharmacy practice into real practice. And not just regular practice as in the US, but under challenging conditions because we don't have all the tests that you may want to do. We don't have all the medications. So you got to be able to make really good, sound clinical decisions, not just based on what we can do in the US, but what we can do at that point. All of this is done in a framework of an interprofessional setting, meaning there's not just pharmacists, there's doctors, there's nurses, we have counselors and other healthcare workers, and we work as a team. And so the students learn how to work in a team, what their role is in the team. They get to rotate through the different stations, so they also get to see what the other healthcare workers actually are doing. So they gain a good understanding of this interprofessional collaboration. Well, this Reciprocal nature, meaning that both the student as well as the community benefit from this interaction, makes it a great a tool for service learning, where the emphasis on learning, which means that basically you learn by serving. And PBA, you may have received one of the nice cups with the QEP logo, reach out, reach in, reach up. PBA's quality enhancement plan for the coming years has to do with service learning. And so this medical mission is part of this curriculum. So we went to Uganda. We've gone there a couple of times since 2013. And you can see Uganda's location in East Africa, right up Lake Victoria. And we actually fly in to Entebbe, which is the national airport, which is close to the capital, Kampala. And then we take a bus ride. Although it's just 35, 40 miles, it takes about 3 hours to get there, because transportation is a challenge. From there, we kind of stay in the Mukono district, which is this whole district highlighted here. And Mukono is the capital, where we stay in a hotel, and then there's 5 different villages that we serve. And Tanzi, which is kind of the center of the area that we serve. And it's the center because one of the local churches we work with, they have their main church there. And from there, they've done certain church plants. And so we visit some of those towns where they have a church plant, or where they want to start a church plant. And it includes the villages Bunakija and Punge and Lulagwe. And then we also go to Seta, which is a little bit of a bigger center. And there we collaborate with an orphanage, Grace Orphanage, which is financially supported by the Gregory family, and which is the same Gregory family that gave name to the Gregory School of Pharmacy. So it's very interesting that we even have that connection over there. So when we're there, we set up health clinics. And we have different stations. So here you see in blue some of the stations that are GSOP, Gregory School of Pharmacy, operated, and some stations that are operated through other organizations. We collaborate with an organization called Hope Smiles, which provides dental care to these people, mainly cleanings and extractions. And we work with the National Health Services. They provide HIV counselors, and we work with them. But from our part, basically what happens is patients go to a waiting area, they get assigned a number. When the number is called, they go to the triage center, where we take some information, and we put them in the system, and then they basically go to the doctors for the diagnosis, and they will make a recommendation for pharmacotherapy. And there may or may not be a need for diagnostic tests, for example, blood glucose levels or malaria tests. So we have a station that does that types of blood work, that type of diagnostics. After that, all the information is gathered, and the decision has been made what kind of pharmacotherapy the patient should receive. The patient moves to the next station, which is the pharmacy, where they can receive their medication. In the pharmacy, there's a verification process to make sure that indeed the recommendation of pharmacotherapy is appropriate for the disease state. So the dentists are part of this program because we provide medications for some of the patients that would require some medications after the procedures. And we work with the HIV counselor because we provide the results for the HIV tests that are done by this HIV counselor. HIV is a big problem in Uganda, and the government has a lot of governmental programs to make sure that people are diagnosed and then can get treatment. So this is what a patient would be. So you'll have your family, and what they will have a sheet of paper, and they will move from station to station. So they receive their paper, and then they move to the triage, where we fill out some information, and they go to the doctors, and from the doctors they go to diagnostics, and maybe back to the doctor, or they go from the diagnostics straight to the pharmacy, or from the doctor straight to the pharmacy. And one day, when they're in the pharmacy, this paper also works at their prescription, and they will receive their medications, and then they go home after they receive some counseling. So this is how we historically done it. So we use paper forms. You can see at the right-hand side, you can see an example of the paper form. And it's used for 2 purposes: documentation of information, but also communication between the different stations. So there's different parts of this form, and in the different stations, we'll fill out different types of information. So in triage, we'll get their name, age, medical history, their medication history, etc. In the diagnostic labs, we can fill out whether there's some of the tests that have been requested by the doctors are positive or negative, and then based on all that information, the doctors have their diagnosis and they suggest a treatment. So this paper is then taken, so it's taken by the patient to the doctor, and then from the doctor to the diagnostic lab, and then back to the doctor, and then back to the pharmacy where we see it and dispense the medications. So documentation and communication, both of those have some challenges. So what are the challenges that we may see with these forms? So here you see some real life examples. So papers become easily messy. Here you can see, I hope you can appreciate it, there's a big footprint here on the form. Sometimes people just fold them and unfold them, so they become messy. It may rain, and then they're outside, and then the forms become wet. Sometimes we have to edit information, and then we just have to cross it out and retype information. They become really, really messy. Another problem that can be that I'm not really blessed with good handwriting, and I'm not the only one. And then so if I write on the form or someone else writes on the form, I may be able to read it, but someone else may not be able to read it. So poor handwriting will make it sometimes very difficult to kind of see what kind of information is there. And that means that it takes longer to process the information. And then it means that the longer it takes, the fewer patients you can actually help. Because at some time, you got to call it quits, especially when there's no electricity, there's no light. So when it gets dark, it is dark. Another problem, again, when it rains, you can get these smudges on it, and that make it more difficult to read at either station. Well, another problem that is that paper is restricted in space. So when a paper is filled out, that's kind of all you can do, and it can be for multiple reasons. For example, a patient may have more than 4 different main complaints that they come in with. So we have to then maybe write 2 in one box, and that may become more complicated because then we have to match up what medication is for what disease states, so that makes the verification more complicated. Another issue is that not all families have 3 kids, and the paper has space for 3 kids. It's not uncommon to have 8 kids. So then space is really restricted, and we have to use different forms, and we have to staple them together, or they have to keep them together. So that makes it more complicated in the long run. Well, also the challenge is that the patient is actually carrying the paper from station to station. So you depend on the patient for the communication lines. Once we're done with a medical mission trip, we want to analyze data. We want to see how many people did we serve. We want to see what are the age groups, how many kids did we serve, how many adults, what kind of medications did we dispense, how many, in what villages. So that helps us to prepare for the coming years. That's very labor intensive with paper forms, especially when you can hardly read them and when there's been a lot of edits. So that's not ideal for students involved at the end of their rotation. Also, with these types of forms, it's not like we bring them the next year. And then so if the same patient would come in the next year, we wouldn't be able to recognize that patient or pull up his previous medical history, what we've done with this patient, to see whether maybe they would need something different now because we tried something last year and it didn't work. So we cannot really do longitudinal follow-up in that sense. So we decided an idea to kind of solve all these 6 problems would be to create electronic health records. That would be so we'd be able to read them. The people didn't have to carry them. We can communicate between stations directly, and it's also helpful for data analysis. So the aim of the study is basically threefold. We wanted to create this electronic health form, these health records, and then we wanted to create, secondly, a network that we could use to look at these forms and to send them from station to station. And the challenge for that is that we want to do that in villages where there's no electricity or Wi-Fi connections. So we have to have a system that can run without power. And then lastly, we want to make sure that all these changes are not just cool looking, that we go in with an iPad in rural Africa, but it actually positively impacts patient care. And so that is maybe the main goal that we want to achieve. So the first goal, creating the electronic health records. So we were able to create these records in collaboration with a company, Infotech Solutions and Consulting. And it was great because I asked a student to participate in this study, knowing that she would join. She had joined and she would join again. And then it turned out that her parents actually have a company. And what they do is they create health records, electronic health records. So that was really a big blessing, and they really helped us out. So they created electronic patient health records. They were based on the paper form I just showed. And basically, it would solve a lot of the problems that we have. We weren't restricted to the number of diagnoses or the number of patients. We would have a drop-down menu for medication, so it's easy to kind of see. We hope that we could implement like a real-time formulary, so what drugs we would have and how many, but that proved to be too challenging because it would restrict us with what we could do when we're there, adaptation-wise. We could save information and forward it from station to station. We could look at the same time. We could look at multiple forms at multiple stations. We could access it using iPads, or laptops, or even phones. What's really important is confidentiality. Although we're in rural Africa, I can say so what, but that is important. And because this is data with patients' names and information, so all the data was encrypted, and also access to these forms was restricted by the use of passwords. So we were able to achieve our first goal. So green box, yes. So the form would be useless if we wouldn't be able to create a network. So that was our second goal, create a network. So we used a laptop computer that was the server for this program, and it has a battery, right? But as you all know, they don't last 12 hours. So we needed power packs to kind of supply lasting power to the laptops. We were able to do that for over 12 hours. And then that server was able to create a local area network where we could then connect all the other devices to access the forms. To make sure that our connectivity reach was large enough, because each village is different, and sometimes we're in different buildings, in different villages, and then they're separated by space. We used a specific enhancers, signal enhancers, that would broaden our range. So here are the signals enhancers, and then we can have more, a wider range, so it would be easy to set up our clinic. And then basically each clinic station would then be connected to the network. So it worked. And it didn't only work here, it also worked in Uganda. So here you see some of the examples. So on the left-hand side, you see Kayla Langtree, Kayla Euler now, who is setting up the server. And you can see it's a nice building with a nice swept dirt floor, no power outlets, no electricity at all, and it works. Here you can see then what happens is data entry at the triage station. You'll see here two pharmacy students, Mernouche and Paku, who are triaging and entering data in the system. You can see here the iPad that's being used for that. Well, from that, I said they rotate to the doctor station. So here you see Darius and Dr. Soriel, one of our pharmacy faculty, working with one of the local doctors, Dr. Moses, and they're working with the people in this specific village. And again, they use iPads to enter the data. Here you can see one of our pharmacy students, Giancarlo, working in a diagnostic lab and performing some blood tests with these students. And again, we could enter that easily into the system. And then the last station here, the pharmacy, different stations. Here you see another of our pharmacy students, Jacob, and one external resident we brought with us, Dr. Roddy. And they're entering data, but also reading all the information. So they're able to, at the pharmacy, you're able to kind of read everything. So you can double check to make sure that indeed the right medications are prescribed for the condition. So it's not just, okay, they want drug A, I'm just going to give drug A 20 20 tablets. No, is the dose correct? Is the indication correct for the medication? And is the duration correct as well? So the whole process of verification is very important. You can see that it depends on where you are. Sometimes we have tables. Sometimes we don't have anything, so we bring a small little table so we can use that to count tablets, etc. We were able to really have a functional network that enabled us to use these electronic health records. So we were able to accomplish these goals, but we had a few challenges. And the biggest challenge was on the first day. We would have network interruptions, approximately like every half an hour, 45 minutes. And we had to reset the system. The laptop would go into like a sleep mode, and then we would just have to reset it. And then if you lose the laptop, you lose your whole network because the area network is no longer available. So people would be in the middle of data entry and then it was shut off, and that's very annoying. People got really upset, and so after some time we just decided to, for a short-term solution, switch to paper forms, which we had brought as a backup. And then in the long run, we were able to configure the server so these problems would no longer occur. One of the signal extenders went missing after the first day. That's a nice way of saying it was stolen. And so now we're down to one, right? And we still had to go to our village with the longest range. So what we did from then on, we securely fastened the extender and just get one of the local kids, and you pay a few dollars and they're guarded with their life. That helped. And sometimes they were kind of, some students were complaining about slow data entry at the doctor's office using iPads, and because of the challenges we had little keyboards. But we had brought some additional laptops, so we were able to use the laptops later instead of that, and that was easy to copy paste data and to type a little bit faster. But it worked. We had some challenges, but we were able to overcome them. So then we went to the third goal, and it was to improve the patient care process. And one of the things that we wanted to look at is, can we serve more people with this? Is it more efficient? So we looked at basically how many people do we serve per doctor per hour. So we have multiple doctors, typically 2 or 3 doctors each day. We see they work an X number of hours, so you combine that for all the doctors. And then the total number of patients is divided by the total number of hours for all the doctors. And then you get the number of patients that you serve per hour. So if you see here in this table, you will see the different villages that we went to on the different clinic days, and the different forms that we use, either the electronic forms or the paper forms. Like I said, on the first day we started electronically and then we finished with paper. And the interesting part is you can see that when we looked at how many patients we actually were able to serve per hour, that we were able to serve more people per hour using the electronic forms than when we switched to the paper form, which is interesting because we started with the electronic. So for a lot of students, it was the first time they're actually serving on a medical mission, so they had to get used to all the information. And even then, it was already faster than when they already got a hang of it after 2+ hours because of the interruptions, switching to the paper. The next day, and we decided, okay, we're going to start with the paper to prevent some pushback. We'd solve some of the issues. We're just going to use paper. We basically got the same number of patients per hour. The third, the fourth, and the fifth day, we used electronic only, and we're able again to serve 10 to 16 people. So you can see the more experienced people got, the more patients we were able to treat per hour. So overall, we were able to serve 50% more patients per hour using the electronic system, which is huge. Like I said, we're restricted. We're there for 1 day, and when it's dark, we're kind of gone. And so the more we can serve during the time we're there, the bigger the impact is going to be, because then we can help more people. So the fact that we can help so many more people per hour is going to have a huge impact in the coming trip. On top of that, we also noticed that it was easier in the whole healthcare track. We can track patients. We can see how many patients are still waiting between one station and the other. So we kind of see, okay, slow down a little bit at this station, move a person to another station, make sure that the backup there is solved, and they can go back to triage, and then at some point they're going to help pharmacy to make sure that the flow is good and we don't get backed up at the end of the day. We can also use the system. We have basically 2 different forms, and one form is basically for patients that need immediate help. So we can see that on the form, whether it's whether they can wait for the normal turn or they have to be seen immediately. For example, a young child with very high fever, we say, okay, you're not going to wait another 4 hours before it's your turn. We put them in an urgency a line, and they can be seen as soon as the next doctor is available. It was also very helpful for dispensing medications and also the verification process, because when you can read everything, it's easier to do the verifications. It's also easier to communicate between the stations, and that improved overall healthcare. So we were able to implement the electronic healthcare records, and even in villages where there's no electricity at all. So in the orphanages we work with in CETA, there were power outlets, so that really helped also to really get a 16 patients per hour, because then it's just easier to create the network. But we could use the form, and it improved the patient care process. So this is great news for medical missions, because if we can do it in rural Africa with no power, you can do it virtually anywhere in the world. The only thing you would need is maybe be able to recharge it overnight, or bring enough power packs to sustain it for multiple days. I would recommend that if you want to start something like that you partner with a company that knows what they're doing. So that saves a lot of time. It's also important to train the students with the system before you go, so they don't get antagonistic at the trip, like, oh, the system doesn't really work well, and it just takes a long time. Because students sometimes don't realize that typing is so much faster sometimes than writing and go back, that even though it's a little bit slower, it's still faster overall. Well, medical missions are often done, but the impact of medical missions are often not studied, meaning that we don't know the long-term impact of these medical missions, or even the short-term. And we don't even know whether it's beneficial or harmful. So studies about the impact of medical missions is really important. And medical records, especially now with these electronic medical records, are really helpful tools, because then we can look at the impact, but we can also kind of see where we can follow up longitudinally from year to year, because it's a great tool for data collection and data analysis. So I'd like to thank everyone who was involved this year. So here you see the team that we work with, which consists of a lot of pharmacy students from our Graduate School of Pharmacy. We partner with one of the local organizations there, is Word Indeed. They work there 24/7 for every year. They have schools and other programs that they do there. And they're actually based here in Palm Beach County. So we have close relationship here, but also when we're there, it's close relationship. So that's really helpful as well. We'd like to also thank the Gregory Center for Medical Missions for their financial support. And of course, Infotech Solutions also for their input and their expertise. So this study was financed by a QI grant from PBA. And we also like to thank PBA for their generous support in this area. Thank you very much. Any questions? Yes.
Have they had any problems with losing data or electronic malfunction?
No. So we did not have any problem with losing data. No. So we still have all the data. Yeah.
Is the hardware stuff that PBA owns, or where did the hardware come from, and do they still have it?
Yeah, so the laptop was donated by Infotech Solutions, because they needed a system that they could work with, and to make sure that it was compatible with what they wanted to do. All the iPads are owned by PBA.
Cool.
Yeah, we even brought like a little a lightweight printer, so we could print some labels or some other information sometimes if that was necessary for people, and that they worked really well as well.
Well, this is a brilliant project. This is just unbelievable.
Thank you.
It's world-shaking.
Yeah. And it actually works.
Yeah.
Yeah.
Continuing on that, I agree, very nice. But rather than have other groups created over, is there any way that can be shared?
Yeah.
Is it compatible with other?
It should be, but yeah, I'm not the intellectual owner of the program.
Center for Missions maybe could facilitate that.
Yeah,
right?
but I think it would be great if it could be made available, and then people can just use that program and use their own devices and then run it.
Was it people from
Yes.
My goodness.
Yeah.
Are you gonna publish a paper on this?
The intent is to, it was rejected by one journal, so
That's okay,
they always do, but you've got to try high and then see where it ends up. Yeah, and because the impact was higher than I anticipated. With the, I just thought that it would just be more helpful for like longitudinal thing and data analysis, but that it would have this much of an impact even on the number of patients we can serve is enormous.
It's just not the patients, look what you're doing for the students.
Yeah.
What an incredible experience.
Yeah, and they loved it. Yeah, eventually. yeah. Well, they're afraid that sometimes the first day you have some delays, and then they're concerned that we're not going to be able to help as many people as they hope we could, because they have to wait 5 minutes before the system resets. But now in the end we can show them now, but you actually help more people, and it also helps them to kind of get more savvy with technology as it comes to healthcare and health records. If there's no more questions, thank you for your attention.
Yes.